What time y'all starting? 10 o'clock sharp. How quickly do y'all go in the public forum? Do I have time to use the restroom? Yeah, it'll be after this, but. All right, thank you.
Okay, I have 10 o'clock, so we're going to go ahead and start the meeting. If I could have everyone stand for the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Good morning. We're going to go ahead and start. Has everybody reviewed the minutes from the last meeting that was held in November?
Yes.
Do I have a motion to approve those minutes?
Motion.
In a second. At this time, we will approve those minutes, have been approved and voted for. Next, we need our public speakers. If you wish to speak, you need to sign up at the front. We have Mr. Joel Sampson as our first public speaker.
Good morning.
Good morning.
I thought I would speak, but I thought I better type it out so I keep all my thoughts straight, and just had a 3-block walk from the wrong building, so pardon me about a lot of breath. And as a 30-year resident of Escambia County, while not a native, I take tremendous pride in what the county and city offer in terms of natural beauty, the people, the history, and much more. Over this time, I've had opportunities for career moves to larger markets, larger salaries, but ultimately chose Escambia County and Pensacola as a place to raise my 2 children and be the community where I hope to retire someday. While I have great appreciation for the work being done by this board, CORE, Florida Health, Escambia County health officials, as well as law enforcement, the early efforts appear to me to primarily focus on the so-called end users, those who have already begun to enter in the midst of the nightmare of addiction and can only hope when an overdose happens, someone has access to a Narcan pen. While these efforts are desperately needed, I believe an abatement program should include not only awareness of help available, such as the hotline, national, state, and county websites, but also speak to those who are at the crucial crossroads of choice. They may have been prescribed opioids for pain or injury, have recovered, but can too easily fall into the trap of addiction. So if we talk about, for me, marketing, it's about capturing moments, whether it's the moment a person is no longer able to secure a prescription from a doctor, or maybe has a friend or dealer who helped nail their addiction, who's been arrested or overdosed themselves. The marketing purchase funnel for Marketing 101, if you remember from college, can be applied not only to the steps that lead to addiction, but also the steps used to get the help they need, whether we're talking directly to those addicted or maybe to a friend or loved one of someone in the various stages of addiction. This funnel starts with awareness and ends with action. Are residents aware of the help that is currently available? Are they aware what lies along the path of addiction? What life-changing critical decisions are in front of them? This plan needs to meet those requirements that have been laid out specifically, including specific attribution, whether it's website traffic, hotline volume, or social media engagement. With the funding resources available, we have this one chance to make a concerted effort to stem the tide and reverse these trends. I believe getting further upstream before addiction takes hold is a worthy tactic in use of these abatement funds. We need to engage the entire community for this to happen. I'd like to request an RFP for plans to adequately fund an awareness campaign to help prevent and treat abuse and overdose, someone sneeze, excuse me, overdose with education, also raise awareness of the life risk danger they may be facing before they become addicted and become another statistic. Full disclosure, I work for iHeartMedia. I was the program director for TK101 for 20 years. I moved to digital sales about 10 years ago, and I believe we have the assets to address these needs, and would just like to see an RFP so we can put that plan together. Thank you.
Thank you very much. Our next speaker is Larry Downs Jr.
Hello. Larry Downs Jr., Plumbing LLC, because fecal matters. Alrighty, I just wanted to read y'all real quick. I'm assuming probably most of this opioid problem is driven by pharmaceutical companies, corporations, we should say, big ones. So anyways, the Florida Surgeon General put out a letter yesterday. No, it wasn't. It was Thursday, January the 3rd, so it was Wednesday. Here it is. Florida Surgeon General calls a halt in the use of COVID-19 mRNA vaccines. Now, we should just say no to pharmaceutical drugs of all types. I mean, they're in the business to make money. How do you think this opioid thing happened? Money. Now, they have how many? 6 COVID injections? For money. There are problems with it. DNA integration could theoretically impact a human's oncogenes, the genes which can transform a healthy cell into a cancerous cell. Y'all should check this out. I know everybody wants to see no evil, hear no evil, speak no evil. But man, they're captured. They're captured. Our bureaucrats are captured. Our media is captured. Florida Surgeon General on Thursday, January 4th, they report Ladapo calls for a halt in the mRNA vaccines. Very next day, Friday, the 5th, COVID-19 cases spike over the holidays. Hospitalizations, emergency room visits, deaths rise in Florida. Y'all seen what's happened. I'm going to go to every county meeting that I can possibly attend in the public forum because I stand with Dr. Joseph Ladapo. He's been calling this since May of 2020. And now it's just amazing to me that the system, the medical system, our government systems, and even our school systems, I mean, you name it, they are on board with these injections. Chemical concoctions containing simian virus 40, SV40. It just goes on and on. So I think it was somebody in the government or somebody running for the government back in the 80s. Just say no to drugs, right? That's what they said. I've been saying no to drugs my whole life. Because one, I like to be in control of my life. I don't like to have other people, organizations, corporations, or government controlling every aspect of my life. Whenever they start giving you drugs, whether it's through doctors' prescriptions or through our government agencies like the CDC, the FDA, you can't trust none of these people. None of them.
Thank you.
Thank you.
Our next speaker, Tawana House.
Thank you, Vice Chair. And to the advisory board members, thank you for allowing me for this moment. I know we have a lot to cover today, so I'll make what I have to say real quick. My name is Dr. Tawana House. I'm a program leader for NAMI Pensacola, as well as a member of the Florida Mental Health Advocacy Coalition. My story is that my 18-year-old son, Rajan House, died due to a fentanyl overdose 2.5 years ago on July 1st, 2021. He collapsed on the gym floor at the YMCA downtown. They had to resuscitate him almost 6 times just to get him to the Baptist Hospital, just to get him to a stable state. He just graduated high school at the time, and he moved out of our house 30 days prior. He was tied up to a lot of tubes and things like that, and unfortunately, for a healthy 18-year-old boy, the fentanyl overdose, along with norfentanyl and Dilaudid that was found in his system, according to the autopsy, resulted in him having a seizure, heart attack, and a stroke to the entire brain that was beyond repair. So a few days later, we had to say goodbye to who was not only my son, but my best friend and the gentle giant. So with the pain that I've had to deal with, our family has had to deal with, that devastated us, his father and I are no longer together. You know, we still have a good relationship for the sake of my youngest son, but by the grace of God and a wonderful village of mine, I'm turning my trauma into transformation and taking the pain that I have to fight for others, not just me, that suffered as well. Of course, we all know about the abatement funds that have come from the lawsuits and things like that. One of the things I'm doing on the statewide level is fighting for people with lived experience, families with lived experience, to be able to serve on the statewide advisory council, because right now, the way the statute is written, it doesn't really allow for that. So I've already been in contact with our state representative, Michelle Salzman, as well as our state senator, Doug Buxton, and about changing that. And I could tell you, based on my conversations with them, they're on board with it. So it's just a matter of the process. As we always know, with legislative process, it takes time, and you have to be patient with that. But I just wanted to show my presence here with you all to say that I'm grateful that Escambia County, my home county, is doing something in regards to this. And I'm just hoping that you will be accountable and integral to us, families like me, people like me, that you will use this money to where it's effective for those that need it, for the families that need it. I'm talking about not just the programs you've always used, but not be afraid to think outside the box, not afraid to do prevention messaging to these children, to these teenagers, about the choices they make, because honestly, the reason why my son is not here is not because it was his time, it was his choice. So thank you for your time.
Thank you so much, and I'm sorry for your loss. At this time, we will move to the public survey results and updated Escambia County opioid statistical information.
Good morning.
Good morning.
As promised from the last meeting, we were able to get our survey out, and I am happy to report that we had over 237 respondents that actually filled out the survey, either through online. It was also available at our community centers and our libraries. So I'm just going to go through these kind of at a high level. I know that you guys have been sent these and you've seen these, and it's going to mirror pretty much what you've heard here today. So just kind of who were the participants. You'll notice that a majority of the folks that actually filled out the survey, I would say was Escambia County's medium income folks, between the $50,000 to $89,000 range. The age and the gender was not shocking. It was mainly African American, or I'm sorry, it was mainly white people with between the ages of 35 to 59, which are the majority of our overdoses categories, and the core team will talk a little bit more about that. So those people really showed up and had a voice. Most of the folks that responded were just Escambia County citizens. They just lived here, they work here, they care about our community. That was the largest majority of folks that actually took the time to fill out the survey. And then, we mirrored a different survey. The 4 categories that we were really focused on was criminal justice, harm reduction, prevention, and treatment and recovery. And the first question we asked on the survey is, what percentage of the funding do you feel like should go to each of these categories? And it kind of was, you'll notice criminal justice had 16 people say 100%. And I'm going to go through what these categories actually were in the survey, because they're a little bit misleading the way that they're listed here. And then prevention and treatment and recovery actually got the most votes, and I think that's pretty much what you heard here this morning as well. So when you look at the prevention categories, the two highest were community and primary prevention. And that goes back to the marketing of the campaigns, the education to our youth, making sure people really realize what this drug does. The criminal justice had three sections. It was law enforcement, community corrections, post-incarceration social programs. A little bit lower of the voting there, I would say, but I think that it's just as important to mention this because those particular categories aren't the policing. Those categories, I just want to touch on this a little bit. So the law enforcement one was actually funding and training for our local police, drug task forces and efforts that prevent illegal drugs from getting to their destination. The community corrections was develop or expand drug or family courts and other law enforcement programs that help people using drug find treatment and stay in our community. And then the post-incarceration and social programs was actual programs that help people recovering from substance use disorders reunite with their community following jail and prison time. So that's what those actual three categories were, just to be clear on that. And then the other category, you have the treatment and recovery, you have treatment expansion and recovery supports, and then harm reduction, we had overdose reversal and family support. So when we kind of look at the overall survey results, the top two categories really are prevention and then treatment and recovery. So preventing those folks from getting there and those folks that are already there, helping them get out. So the community was funding for schools, childcare, family services, and job training to prevent drug use. Primary prevention programs and strategies shown to prevent drug use, including family and youth programs that promote healthy behavior and relationships and reduce risk factors, as well as adult education programs and public education campaigns. I will mention that I have engaged in our local school system, and I actually have a meeting coming up in January just to kind of discuss what Escambia County is doing, what we're not doing, and if there is some room there for us to be able to get into the school systems. We know that's the quickest and easiest way to get to our younger population. If that's not possible, we also have incredible programs at our community centers, our libraries. I know that there are community partners that deal with the youth, so that would be another option that we could target those folks. And then treatment and recovery, the treatment expansion expands substance use disorder treatment. Examples, detox, inpatient, residential, and outpatient treatments, and medication for opioid use disorder, and recovery support. Programs that promote recovery, like access to housing and healthcare, employment, and job training, and peer support programs. So that's kind of where our survey ended up. So I'll open it to any questions before I let the core team take over with any kind of updated statistics that they have for us.
Thank you for that overview. Does anyone have any questions?
Don't have a question, but I just want to commend the staff for putting this together. I would think this is really important. Current information from the community. I think it was really an important survey to be done, and the report and the way it's summarized, I think is very helpful.
Absolutely, you're welcome. Okay, I'll let the core team jump in and kind of go with, and they also have updated statistics. Oh, you got some?
I just have one thing. Thank you for your efforts. Thank you for everything that you all did and that quick turnaround on the survey. And I know we mirrored a survey from another county and how they kind of had it lined out. I think for those two, I'm glad it came out, those two top programs, because when looking at the core strategies of the mandate when it came down, how the survey laid out with criminal justice, the core strategies doesn't lead out with that. So I think we kind of didn't structure that initial, right? I don't want to go back and do it, of course not, but and it kind of came out how the core strategies line up, which is great. So I just want to put that out there on the record that law enforcement is not a top core strategy when you look at our mandate that came down. The prevention, treatment, recovery, things of that particular nature, that's in there. And of course, the educational part is definitely in there. So I just want to just put that on the record of just how this reads. And so just to make sure that we're in compliance with how the mandate, because there was a case up north where a county did put a lot towards a category, and it wasn't, and then they end up getting sued from organizations because it was not how it's supposed to have been laid out. So I just want to make sure that even though we did a survey, and that survey was from another county, that we make sure we pay attention to how our mandates are laid out. Thank you.
I think the other thing too, and that's why I wanted to go through the criminal justice section specifically, is because those categories really are prevention. It's not policing, I guess, is the reason why I wanted to go through those specifically, so that people kind of had an understanding of that.
Thank you, ma'am.
Yeah.
Before we moved on to the next portion, I just want to make sure that the board was aware that CDAC, our task force, was not involved in the preparation of this or the questioning. I know that everyone knows it was taken from another county. But you may want some input at one point from CDAC, since they are your task force, and they may be able to help you as you navigate this process, because there's more than just the surface of the survey. You need to be able to look deeper into that.
Thank
And
you.
that's what we have them for.
Thank you.
Good morning. My name is Joey Kerman. I'm from Escambia County EMS, and I am the lead for the Escambia County Core Program. Some of the alarming statistics, I'm going to give you both the initial and where we finished in 2023. When the data was initially compiled, it was through December 10th, 2023. Escambia County had run a combined total of 10,529 opiate overdose calls. For 1/1/2023 to 12/10/2023, we were at 3,753 overdoses for the year. We finished with 3,902. On 1/1/2020, to put it into perspective, Santa Rosa over the same time period was 1,098, and Okaloosa was 1,897. At the time, it was a 16% increase for Escambia County. We're up to a 19% increase from 2021 to 2023. The demographic makeup was 55% male, 45% female. The primary age range was 30 to 39. They made up 26% of our overdoses, followed by 40 to 49. They made up 16.2, and then 20 to 29 made up 15%. The race and ethnicity breakdown was 74% Caucasian, 21.5% Black, and 3% Hispanic and Latino. Do we have this so we can see? Is it able to be put up there?
I don't think we can put it up there.
Okay. Okay. There's also a map that shows kind of the target. The bottom line and the principle of the map is that it affects every single community in Escambia County, from north to south, from the Key to Gulf Breeze to Pensacola Beach. So that was kind of where we were at. I'm going to turn it over to Chief Torcell.
Madam Vice Chair and board members, good morning. When we first came to you to give you some information about the process we had in plan for our core program, we had a planned out strategy for what was best fit for our community and what we thought was going to be the best intention of how core program would impact our services here. Certainly the other 8 counties throughout the state that were selected as part of this initial trial of the core, each was expected to implement their processes based on what they felt was going to be best for their community. So that's how we set up our initial model. I will say that probably 95% of that initial model has still stayed in place from inception. Certainly, we've understood some things with our growth. We've figured out some better practices and processes in dealing with patients, dealing with our community partners. But that initial plan we have for core to to capture patients that are just continually in the cycle of overdose, 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 go to the hospital, be discharged, go back and overdose, get transported to the hospital. To me, that was just completely unacceptable. And that's where we were. It was an expected thing that, well, that's just overdose and that's drugs. And I would reiterate again, we talk about the same things. It's okay to talk about heart disease. It's okay to talk about diabetes. It's okay to talk about cancer. But when we start talking about drugs, ooh, that's gross, that's ucky. Well, that's one of the biggest problems we have at a tremendously alarming rate here in this community. I mean, it's a terrible thing that we see these numbers. And despite some great efforts that we have, and I can't give enough credit to this team and what they've done from both a professional and personal level to take stake in this, but it's an alarming thing, and it's something that we want to continue to keep working on. Our medication-assisted therapy, our MAT program, is working fantastic. The warm handoffs between the hospitals and us, where we are capturing these patients from transport to hospital. Before discharge, they come back and get recommended into our program, and we now have additional resources through Lakeview that we've been working with. I'm looking very forward to the centralized receiving facility potentially down the road that's going to be opening to add more resources to our community. Pardon me. And it's just grown. We've watched it every day. We've made some changes just slightly here and there as to scheduling type things and how we do our visits. But we have seen a tremendous impact. We have statements from these people that came into our program that basically ended their statement with, had it not been for the program, I would be dead. I don't think anything could be any more impactful to any one program than somebody saying, if it wasn't for what you all are doing as a team, I would be dead. I mean, that speaks volumes. And with that, we're going to continue to do what we're doing. We're going to continue to track this information. We take suggestions and ideas from everywhere. We certainly don't think we have the most perfect thing in place, but I will tell you it has been tremendously successful. This team, not only with the MAT and the treatment and everything that's happened, they've managed to assist in getting these folks jobs. We've assisted in getting them clothes, personal hygiene things, places to stay, a simple phone, because they need to have communication. I mean, how can you make appointments and call places where you need to go for therapies and treatments if you don't have a way to communicate? We also, as you know, as part of our initial core program, we provide the transportation for those people in that group that need it, not only just for the treatment modalities, but, hey, these same people that are already lacking transportation services, already affected by drug addiction and mental health issues, have other co-medical problems that they have to have appointments to. Well, if we couldn't get them to their drug appointments, how are they getting to their eye appointments, to their doctor's appointments? They're not going to be successful if you don't give them that full wraparound support. And the last piece is, our funding strategy that initially was set in place with the state of Florida. That was through the Department of Health. That has ceased. We now fall under the Northwest Florida Health Network, which is through DCF. I will say, being very professional, we have had a tremendous difference in the response with Northwest Florida Health Network as to how quick their turnarounds are, their communications platforms. It has really bolstered our ability to keep things rolling for our patients. And it's one more thing. I have asked them for the ability to provide a social worker through us, because one of the things we're finding, again, with those wraparound services, not only through the addiction piece and the opioid piece, but a lot of our patients in EMS, sometimes we get those roadblocks of how to best help them and where the resources are to get them. And that social worker is another piece that's going to help guide us to where we need to be to get these patients successful and get them to graduate through our program. So I think, we're going to continue to do what we're doing. I think we've seen great results, and I look forward in 2024 to better results. Thank you.
Thank you so much. One of the wonderful things about the core program is the wraparound services, and that is the crucial piece of it, being able to take people to those appointments. I definitely see that a lot. Does anyone else have any comments or questions?
Yes, I have something. Two questions. Chief, do you see that do you have enough boots on the ground in what you do?
That's an excellent question, because numbers of personnel, and I'll give the example of, and this is, I think, a good platform to use it. Numbers of personnel that we have, let's look at just our regular EMS platform, right? We run EMS calls, we run 911 calls, we run interfacility calls all day long. Being fully staffed on a piece of paper that says, hey, every position you have set up is full. But am I adequately staffed? No, I am not. We are not adequately staffed in either way. And to have, right now, we have a group of 4 core nurses and 2 EMTs. So that's a group of those 6 people doing all of that work in 12-hour shifts. With the expansion of a social worker to get that other piece for where to get them the resources they need is tremendous. But in truth, to have more boots on the ground for that program, because we're getting called in so many different directions, we may have multiple people, patients, mind you, at multiple hospitals at the same time that need an induction process at the same time, and we have to hold one off to get to the other and then tell them, don't discharge that patient, we'll be over to get that other one. So yes, we always need more people.
And so, with that being said, what would adequate staffing, or let's just say if it wasn't adequate staffing, but partnerships with other entities that could answer those calls with guidance under the core program with under your leadership, what would those numbers look like? Because I understand for you to take adequate staff and then you have to take on employees, but then you may not have the time to ramp up, but then there may be other agencies that have trained individuals that could partner with you that can plug into what you already have to help you answer those calls. What would that look like?
So from a platform of like the core team, and I've already talked to Joey about this, for us to be able to double our numbers from the 4 nurses we have to 8, we still have the transportation piece there, which is working out tremendously. We haven't been overwhelmed with that. But when you start looking at the community partnership piece, those that can provide the pieces that we cannot. So the long-term addiction therapy, that's not in our realm. The long-term mental health, because those two go hand in hand. Both in Lakeview with the partnership that we have with them. I've certainly talked to Dr. Williams before in the past, and we've sat through meetings through those processes. Most recently, prior to the holidays, I met with Mr. Rodney Jones with his organization to start talking about expanding that to have those other resources available, because this is not anything that one team can handle. We need as many partners and as many resources as we can get so we have places to refer, so one place is not overwhelmed with those patients.
Excellent. And that leads me into my last one. What about the treatment facilities? Do you think Escambia County has enough facilities or beds to actually deal with these numbers that you're saying? You're like 10,000 calls between calendar years, or so to speak?
Yeah, for those 3
calendar
years.
year. And when you look at those calls, how many of those out of those calls would you say would have to have longer term? It wasn't like, okay, I accidentally took something, I thought something of that nature, and then they just kind of like, okay, I won't do that again. But the ones when you look at the longer term addiction that actually needs inpatient services and actually have to go through a serious program because they are seriously addicted, not the accidental ones, but the ones, what would you say that percentage of those, that 10,000 plus calls?
Easily 75 to 80% of those larger pieces are of those, that total call volume are going to be the ones that need that long-term, and there's a term out there that's called lifetime therapy, lifetime addiction therapy, because someone may need it forever. There are those, absolutely. And I just heard that someone say, right, there are those that have great success that we have seen where they go through for a period of time, they get through their MAT. We call it a graduation, because that's what I believe it is. You're graduating to the next level in your life to get back to what you consider normalcy, right? But many of them can't do that just with some MAT, a few appointments, and back to being, what we all would all consider to be a normal life. They need something long-term because they have those cravings down the road. They're around social situations that may bring them back to where they were. And continuing down that pathway with that long-term thing for probably 75 to 80% easily is something we need. And to answer your initial question, no, we absolutely do not have enough facilities, enough beds, enough of the ability to serve the addiction community here currently in Escambia County.
Okay.
Joey.
I know I said it was last.
I want to add one more thing.
Yes, sir.
We also don't have enough safe places and safe beds for women in our community. That's something we've encountered quite a bit, where they're going back to the traffickers, they're going back to the motels all along. That's the hotbed of addiction. That's why we have such a repeat offender population.
Okay. And my last one, because I'm a kind of a numbers guy, a chart guy, and I'm looking at your graph here, and And Miss Tawana, she comes up. She, you know, I get kind of really sensitive about this situation. She has the same story as Miss Stephanie that came to us when we first started. Identical. Identical. And so I know that the numbers here is between the 20 to 39, things of that nature. We say that is the number in which the overdose, you're seeing them. What I'm looking on this graph, and I look at the 0 to 19, that number is steadily rising.
It is?
It is hitting now 500. Now think about that. That is 500 that was called. That's not the numbers that are using or the addicted that has not overdosed and has not been called yet. So, and again, I go back to this, and Ms. Tawana, she said her son died at 18. Miss Stephanie's son died at 18. They didn't start using that day. Miss Tawana, and so Miss Stephanie tried to get treatment for her son here for months, for years in time before that happened. And the reason I ask these questions, I zone in on this, and I'm looking at these numbers. The 20 to 30, 39 seems like it's kind of holding steady with a certain number. The 45 is kind of holding steady, 60 plus, it kind of creeped up a little bit. But what really concerns me in this draft, this chart, is at 0 to 19. Because it's silently creeping up. If you look at from 21 to 23, it's silently creeping up.
I think too, the gentleman's next to me, they're a great resource for a lot of things. I mean, they're in it every day. But one of the things they just said was, you can't affect the supply, but we can affect the demand.
Yes.
And I think that exactly what you're saying goes down to what the community is saying, and that is the prevention with our youth, and also the increased treatment for those folks that are already in it.
Exactly. The survey did the people did a great job. I just wanted to put that on record because of what Chief said, and what his assistant said, and what the survey said, and what the community is saying. I think we have our targets. I think we have our targets. I think we have our the direction in which we need to go, and now it's time to just kind of like let's get there. How do we get there? And I thank you, Chief. I thank you all for being here. I thank you for the ones that came up and spoke, and everyone else that's in the audience, because this is pretty serious.
We do also have CDAC here, and they have provided some updated stats as well. I don't know if they want to talk at all, but they are here if you guys have any questions for them.
Denise, did you want to come up and?
Just a
Thank you.
moment, just for the record, what I've handed you, what was previously provided to this board in June or July of this
It was July, I believe I sent it.
2023. So this information was also provided to Liz Kessel, but it was not provided or added to any of the documents that was received here. So we can republish that. For the purposes of public record, we can republish this with the minutes, since it's something the board is reviewing. Unfortunately, we don't have any way of putting it up on the screen for the public to see, but she can certainly talk about the numbers, because this is that youth group
Okay.
that we're talking about.
Great, thank you.
Catherine, you have all I don't have a copy. So, and this is another copy. So discussing adolescents and youth, the best thing that right now currently the state of Florida has is what's called the Florida Substance Abuse Youth Survey. It's been tracked for many years. I've been at CDOT for 19 years, and the whole state has used it. So it's the best data that we have. Now, they do compare it, and you can do a comparison to the national data that is also published. So when we're looking at adolescent use, currently in 2022, the most active use, I'm sorry, I don't have my reading glasses on. So really throughout current history, alcohol has been the #1 drug of choice for our adolescents at a higher rate in Escambia County. And then you're looking at vaping now is the #2 drug percentage-wise when you're looking at nicotine. But if you look at the vaping rate with marijuana use and you combine those two datas, it's going to be #1. Vaping is going to be your #1 drug of choice, even exceeding alcohol when you look at the whole vaping perspective data-wise. So adolescents are using at a rate that is very concerning, just not in Escambia County. Across the whole state. So when you're looking at prevention, yes, prevention really starts, I would say below kindergarten, because it's not, sometimes as far as prevention goes, not necessarily about the drug behavior, it's about the behavior that we're trying to teach our kids prior to that. It's about problem solving, it's about how do they manage these feelings that they're having so they don't use. There's many prevention models out there that are good curriculum models that have been known to be successful. So when you're looking at any death related to a overdose is horrific and it's terrible, no matter what age. Unfortunately, when we lose adolescents, it's even more traumatic to the family members. So prevention is the key. Because if you get them at 3 and 4, hopefully they're not going to use when they're 35. But we do need to tackle the problem that we're seeing. I would like to comment, though, on what EMS is saying. There has been some recent, in the last 4 or 5 years, really good dialogue around peer support and case management. It is key. If you talk to somebody in recovery, that's probably going to be one of their key concepts right now. There is a couple model programs that they are using now for adolescents as well, like peer support within school systems. So there is a couple models out there that look at that as well. But that's key to their success. I think if you talk to anybody in recovery, they're going to say it's people, places, and things around them that's going to get those through those moments. Now we do have AA and NA, that's for free. That is considered peer support as well. But case management and peer support is going to be key. Now I do work for CDAC, so CDAC has case management and peers at CDAC, but I know other organizations are really looking in that. If you also look at other states, some states also have funded peers in the ERs, and they've also been very successful. But you're talking about that's high manpower, but it's very known to be very cost effective in the long run. But you're going to have to man it 24 hours a day and have that conversation with ERs. And to have that space for them, that case management and that peer support. For those of you that don't know, now peers in the state of Florida have to go for a rigorous educational process. It's very rigorous. Rodney, are you a peer? Yeah, Rodney's a peer, so he could talk about more. I'm not a peer. But it is a rigorous process, but again, it's been known to be very successful. I know I went on. Any questions with that? And I can send this to the team again if you want.
Yes, if you would send that to us.
Okay.
You could just send it over to Tina Arroyo,
Yeah, I'll send it to
and
Tina.
then she'll distribute it to make sure we don't accidentally get any type of public record violations.
Okay, another thing that I was able to provide Elizabeth, which is looking at other counties and other states, what they've initiated with their opioid money. So I was able to provide some of that information to them. All right, any questions?
I have one. I'm sorry.
No, it's okay, Mr. White. Put me on the hot seat.
And this is for Chief and yourself, whomever can answer this. I see this number crept up to like 500 youth in 2023. Of that percentage of 500, what percentage of that would you say needed treatment, or was it accidental? See,
Most of them would be considered accidental. And I'll put it into perspective. We have Narcan someone as young as 6 months old. That's me personally. Up until we've had folks who thought they bought a pill, it was a press. They thought they were getting a Xanax, it wasn't. It was pure fentanyl. That's the kind of overdoses that we see in more, they don't go straight to fentanyl. There is an evolutionary process. Now, recently, the Department of Health did invite the Corps, and I went and spoke to the Pensacola, it was at the PSC charter school. I asked the entire room to raise their hand if they had either overdosed or been a part of an overdose. I would say 90% of that room's hands went up. There is an appetite for our youth who ask very good, very thoughtful questions about the specific drugs that are out there, what to look for. So there is an appetite. It's not like the DARE program of my youth where we still have a problem today, so that didn't work.
so in that statement, you said that, like that one case where they were trying to get a Xanax. Now, that wasn't a prescribed Xanax.
No.
It was coming through a source. So therefore, it leads me to the question of, were they a user? In other words, are they addicted? And therein lies the base, because you have to be, I ain't gonna say you have to be addicted before though, but most overdose because of regular usage. So, and I guess, and let me rephrase that 500 question. Of that 500, how many would you say that when you dealt with them, that they had an addiction?
I would say that target would be the 14 to 18 range, and there you would be seeing, based on that definition, 90% of them
Or addicted?
to something. They want a
something.
mind-altering substance, but I wouldn't say that they're true opiate
Right.
active users.
Exactly. So, and with that being said, once you come in contact with a teen that has an addiction, how do you deal with that? Do you have someone that can treat them?
That's where the community itself has a gap. Once you start dealing with minors, there's a gap. Minors and pregnant females, that's where everybody's like, whoa, 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 hands up. And we run into obstacles. Now, we don't have a choice. We're going to treat you. We're going to identify, treat life threats. The problem is that after the fact, what happens in the hospital? Where do they go? Who's going to be? This is another gap in our community that we have to fix.
Okay.
Mr. White, can I
Yes, ma'am.
comment on that?
Yes, ma'am.
So again, it comes back to prevention. When somebody's drug seeking, they are there because they may have a dependency,
Yes.
but like he said, it usually for adolescents, it does not start with an opioid.
That's correct.
And if they're drug seeking, then it is the mindset. Now, they may be dependent or not. Now, if you do an anecdotal, which I can't substantiate via hard data, but when you're looking at research across the United States, because we are part of the United States, and I don't know if he could comment on that, is they're starting their usage younger, but they're also starting their uses because of social acceptance and learning to cope with their emotions. You can say that it is alcohol, you could say that it's marijuana.
But no matter what it is,
Once they get to a certain point to be identified as a substance use disorder, and maybe Dr. Williams could comment, it is a process to be formally diagnosed. But if they're drug seeking, they're looking for some type of relief.
right. But if we could definitely set things in motion to where, and as I look at this word opioid, this title, opioid abatement, to help them not even get to the point to where they accidentally get a hold of the opioid. To me, that's also what we're here for, because we're trying to abate the opioid
Correct.
interaction.
So there's also been some anecdotal where they're finding fentanyl in vape liquid. So there is, it's adulterated in people that are drug seeking, where that's where you may
Exactly.
see the accidental.
Okay. Thank you,
Matt.
ma'am.
Matt, did you have something that you want to add?
I did. Chief Trussell, with the peer counseling and stuff, peer support, and with the juvenile problem, I know Lakeview, you mentioned Lakeview helps some. Is Community Health, are they involved with anything? I know they have counselors too, but I don't know.
Yes, Community Health Northwest Florida, as well as Lakeview especially. We've tried to reach out to as many, as I said before, as this evolves, sometimes, and it's amazing, but it happens in every community, so we have nothing to be ashamed about, but we have something we need to work towards is, you have all these community partners working together for years, right? I've been here 30 years, and yet they never knew this one offered this service or this one offered that service, and it's like, all you got to do is talk. And as this has evolved for us for CORE, we have found out, oh, you do have those services available. Okay, how do you provide them? What are your hours? What is your availability? And we've used those methods between our partners, Community Health Northwest Florida, Lakeview, soon to be with Mr. Jones. We're going to set everything up to where we have multiple resources, because we want to be able to go, we don't want you to wait for a week or 2 weeks or 3 weeks, because that's where you lose these people is nobody's going to wait 2 to 3 weeks to get into an appointment. They're going to go back and use again, and either we're going to be taking them to the ER, or unfortunately, they're going to go to medical examiner's office. Then we've lost the fight altogether. One of the additional things I wanted to add in talking about the pediatrics and the youth that's very difficult is, obviously, that is not only a very special subcategory, but the other thing you have to look at too is we can't treat pediatrics without parents' permission. So these aren't adults that we're finding overdosed in the street that are unconscious. We can just pick them up, take them to the hospital, and talk to them individually. We have to involve their parents or their guardians or whomever. So there's an additional step in there that while one would think, oh, the parents would certainly love to have treatment for their kids, sometimes those are even barriers, because maybe they don't have a relationship with their kids. Maybe there's just some barriers there that they didn't even know their child was using. And those things can kind of compound the problem. So again, it goes back to, the prevention, the education, specifically, as was said previously, I can't control the supply, but maybe by working through these programs, we can control the demand. So if we shut it off on this end and give the other end, like yourself, law enforcement, to handle that piece, now we come together and really make that bigger picture. But it's going to take time. We understand that. We are not under any belief that this is a magic wand that we wave and we fix the problem. But by God, we're going to do what we need to do to make it better.
So I know Mr. Jones, he kind of he likes the juvenile aspect of it. Besides him, is there any other availability for juveniles that we have right now, or is that the biggest gap that you see?
Yeah, juveniles and again, the women and pregnancy is a big one for us. We do have Sacred Heart Hospital here, which obviously is the pediatric hospital, but even then, when it comes to dealing with addiction and things like that, that's very difficult. So right now, Rodney and his staff are going to be one of the biggest resources for us to help us with this, because when you start to look, holistically, there's, we do all these things, but when you really start to refine it, well, who does that encompass, and what age brackets does that encompass? We all, as we do ourselves, start to realize where our weaknesses are. Oh my goodness, we don't have a resource for that. And those are definitely the big ones, absolutely.
Thank you. I got one last thing. On this map, I see different colors. I see blue, yellow, little orange, green, red. What does that indicate?
Indicates the high concentration of overdoses in that area per the population.
So the blue, what does that mean?
That there might be a 153, but there's not, they're kind of spread out within the area, within the dense population. If I were to scroll the map down, which I could not get to fit on a piece of paper, it would isolate it down. I can tell you by the neighborhood, by the house where we've gone.
Interesting. And
Where we've overdosed.
like the green, what does that mean? Just a little bit more?
A little bit more.
Okay. And the red is like, that's red alert.
Super, yeah.
Interesting. Okay. Thank you, sir.
Dr. Williams?
Just to quickly, to follow up on, Chief, with your comment about the funding from Northwest Florida Network, what's the time frame of your funding? Is it annual? Is it, because obviously that's a concern for us in terms of that being sustained.
Absolutely. So initially what we did when the course started, and I will say we played a lot of catch up, and I'm not going to point any fingers or blame anybody, but it was a bigger picture that I think got wheels too fast before it was ready to drive. And there was a 6 to probably 8 month period where it was talked about. We did press conferences, and I met with Dr. Joseph Latipo and Dr. Kenneth Shepke and all these people to talk about the true basis of detox versus MAT and all these various things. And then all of a sudden we got up, and it was in the news, and then it just kind of stopped because we didn't have those plans in place yet, but they rolled the ball a little faster for us. So the plan we had in place with our agreement with the state was we did it quarterly. Quarterly, we would give them all of the information that was required as per our agreement with everything they wanted to know, all of our data, how many patients have we seen, who are we doing MAT with, down to the time card hours of our nurses and how much fuel do we use when we drive, everything. Unfortunately, some of those funding things has still yet to pan out, even though that was from last year, and we're still waiting for funds from that. Now, under the umbrella of Northwest Florida Health Network, we do it monthly. Every month, all of that information is compiled, mostly, I'll be honest, by Joey, because he is the best at that. He can put it together to where it's easiest to be seen, and that is his, he's my data guy. He knows everything and how to put it together to make it easily explainable. We send all that to them, and within days, we are already given funding for that month. I mean, just that fast, days, we are getting the funding so that we make sure we keep up. So as the program goes, we're not behind, they're not behind. We have adequate funding, they have relevant data. And as we move, like I said, with the social worker, that's the next piece we're now working on. I told them, let's get after the first of the year, the holidays, everybody's in meetings and things. We're going to be sitting down to discuss how that's going to look for us for that next piece, and if it's possible for us to get them on as quickly as we can, because that's another necessary resource we need.
Does anyone else have any comments at this point? Okay, we're going to move to the next item on the agenda.
All right, the next item is the narrowing down the goals for the opioid abatement plan that we have to submit to the state. Escambia County, unfortunately, doesn't fall underneath the Northwest Florida umbrella. However, I have reached out to them. There are some smaller counties that the funding flows through them, just like our core program does. So they have been able to provide us with some guidance as far as reporting and what we're expected to do to establish those deliverables. So the first thing I just want to do is just to remind you guys of the funding that we've received already that's currently in the bank. So for the first year, we received $2,489,263.51. Of that, it looks like the advisory board and the BCC has approved $490,000 to the Escambia County Sheriff's Office for the purchase of 14 narcotic analyzers that will enable deputies and personal staff to scan more than 498 drugs. So if we take that out, the remaining funding balance that you guys have is $1,999,263.51. So I just wanted to remind you guys of that, since that was a while ago that you had approved that. And I know there is another ask on the agenda from the police department today as well. So you should have a implementation plan, qualified counties, kind of an example of what Northwest Florida is utilizing for their non-qualified counties. Obviously, our funding amount would change, the county would change. They've really narrowed down the core strategies, and I think that we, after today, are pretty much in agreement what ours should be. But what I need from you guys is to confirm what those core strategies are, and then I will put this into an implementation plan and bring it back for approval for the next board meeting. So if you guys want to discuss what you want those core strategies to be, the ones we've talked about just off the top of our head, if we wanted to do 4, we had for prevention, we had community, which includes funding for schools, childcare, family services, and job training to prevent drug use, and primary prevention, which is programs and strategies shown to prevent drug use, including family and youth programs that promote healthy behavior in relationships and reduce risk factors, as well as adult education programs and public education campaigns. And then for treatment and recovery, the two categories were treatment expansion, which is expanding substance use disorder treatment, example detox, inpatient, residential, and outpatient treatment, and medications for opioid use disorder, and recovery support, programs that promote recovery like access to housing and healthcare, employment and job training, and peer support programs. So we'll open it up to you guys. You can say you want a certain allocation, if you want to split it 25% for all four categories, however you guys want to do it, I can.
Before you move on into your discussion, let me remind you that this is an area that CDAC needs to be heavily involved. So this may not be the time for you to make that decision, because what you may want to direct CDAC to do is come back with information to assist you in making this decision. Or they may be able to offer it today, I don't know. What we have is what the community is interested in, but you also have to follow what's science-based. So you need a balancing between what the community has focused, and how many, 200 people?
Well, my understanding is that CDAC has already provided the information, and then CORE just provided updated information, so.
I'm sorry, what was it, 200 people that filled out the survey? I didn't catch your number.
Over 227.
Okay, so you want to make sure that what you're doing is taking a science-based approach. You want to make sure that the organizations that you're going to reach out to are using a science-based approach. You want to remember that your organizations also have to be able to keep records and come back to you with what is recognized as appropriate accounting, those types of things. So there's a lot of moving parts here.
That actually is established in the RFP. If an entity can provide all of those things, this is just establishing your goals.
I just want to make it clear, when this first came about, in order for this county or city to get money, a committee had to be already established. That committee was already established at CDAC, and then we had the opiate task force. So I think that's what she's referring to. It's just not the CEO at CDAC, and it's just not me. It is other members that initially, which was, 2 years ago? So it's just not us. It is a task force.
My understanding was that stopped meeting. Is that not the case?
We haven't had any current meetings because we've been going by what they have requested from us. So I don't know how the legal aspect refers to that. That's all I'm commenting on. I don't know what legally what you have to do in order to initiate the funding properly. That's all I'm commenting to. So saying CDAC, it's fine. It's just we're a task force.
So you want your so basically that's the whole, they haven't met because there hasn't been a request from this board. So this board needs to say, these are the things we're interested in, this is what we want, and this is the type of thing we want you to do. Meet with the committee, get back to us, and let us know what we need to be putting into our requests to go out to the public, or to go out to the community partners.
I'm a little confused with that process, because, again, based on what was just mentioned, I think the CDAC chaired group did make input early on, and whether we look at additional information or whether we look at the general categories, at this point, we are not, if we decide on the core strategies, that my way of thinking, we have enough information to do that. The next step would be the detail of what kinds of RFPs go out, and there are some specifics with that, and there was even an example given in terms of very detailed process in terms of qualifications, et cetera, et cetera. So my thought, and we talked about this the last time we met, that we need to move forward, and we need to basic step of moving forward is deciding on what those strategies are. And from my way of thinking, I think we have enough information to do that. There are 4 primary areas, and maybe the question of if we want to assign percentages in terms of the budget to that, that's one question. But deciding on those 4 areas, I think, from my way of thinking, that we have enough information to do that now.
And that's completely up to the board. If you
Right.
recall all that information without, and I know you may have reviewed it before you came in here. You may have, I know you probably recall it better than anyone. So just make sure that you're relying on, that's what we have to involve our CDAC committee. It was part of, that's how we got an opioid board. That's how we became, the county was able to do what we've done with having this OFAB board. So make sure that, I know you remember what they had said, so you want to make sure that you're following along and you're getting the committee involvement in this.
Yes.
So at this point, do you feel like we have not received or recognized, or received the input, adequate input, or recognized the input from the CDAC committee?
I would ask CDAC that, if there's additional information they think they need to provide. But I can't answer you whether or not you've received enough. I just want to make sure that you know that you have this tool that has basically been sitting dormant for a while because they haven't really been asked to do anything. But if you know what areas you want to go into, you may want their input, and she may be able to give it to you today.
I thought she's here every meeting, like giving input. I thought that was the representative from the task force from CDAC, and she was their spokesperson. So wouldn't that be that leg of that committee?
You want to address this for them?
And if you have any information you think that would be pertinent to
I
this,
am not the CEO and head of the committee. I represent the committee, yes. But if you need further information based on the new survey from the committee, that would be something that we would be able to provide. Now, that there was a strategic plan put in place that was given to you from those initial meetings on what we were basing it on 2 years ago. So that strategic plan ideas was provided to you, 2 years ago?
And are you referring to the strategic plan that was listed in the BCC, those 5? I don't know, Christy, if you could help with that, but basically where it says the Escambia County Task Force opioid plan, is that what you're referring to?
Yeah, that's what the
Okay,
CEO,
so it
that's what the
lists-
committee had combined. So that was, I think 2 years ago?
Yes,
Catherine, Ms.
22.
Wire? Yeah,
And it lists in that overdose prevention, treatment, pregnant and parenting women and their babies, warm handoff programs and recovery services, and prevention.
right. So I don't have it in front of me, but the best that I
Yeah,
can
the board-
recall, yes.
Everyone on the board should have that.
What
Yeah,
page
so
is
I
that
don't
on?
think anything has really changed with our needs. It just seems like the numbers have gotten more numbers. Is that right?
As far as overdose rates, from what Mr. Torcell said and his team, yeah, when you look at the data on the people that have overdosed and who they're meeting with on a daily basis, yes, I would say, from what you said, has increased.
So it sounds like we still have the same needs, and we've identified those.
Yeah.
I just want to make sure, that's what I'm trying to do, is make sure you keep CDAC involved in the process. It's the only reason why we were able to have the board that we do and have the powers that you have, is because we had a task force in place at the beginning. And so just make sure you keep them in the works, and that strategic plan is your goal.
Okay, at this point, does the board want to move forward on narrowing down the goals for 2024?
Yes. Well, last time we was here, we had a number of, a number of things, and I know one is coming up on the agenda. But there was a number of requests from Lakeview, the core program, things of that nature. And so I just kind of feel like we're kind of going around in circles every time we get here, and we discussed a expedited way because there's already community partners in place. And I know we're going to look at goals, but after we look at these goals, we already have community partners that's here and that are asking for funding to continue to serve the community. And I want to ask if we can address those also while we're here, instead of waiting a whole nother month.
Okay, I think the first step, we need to go ahead and move toward the goals, identify the goals, and then we can proceed.
Yes, ma'am.
Do I have any recommendations? Who would like to start the conversation?
Yes, I think we have them, even with the survey, and it kind of lined up exactly what, Madam Chair, what you just read out. The treatment and recovery, I know the prevention and the treatment and recovery were the top two. I think the treatment and recovery there should be, of course, number one, because Chief already outlined that there is a serious community gap in the treatment and recovery part, and that's where they're struggling. And it was two areas that they're struggling bad at, that once they hit that, they don't have the resources to deal with them. A, the pregnant women, and two, the juvenile. So under treatment and recovery, I think those two we should be definitely focused on filling those two gaps under treatment and recovery. And of course, the regular adult facilities, helping them to continue to facilitate what they're already doing, like the Lake Views and other facilities that's out there. Second would be the prevention. And that's going to shore up as we were speaking of, like the school programs, catching them while they're young, the educational side, more community programs, funding to community programs, as which I forget your name from the county. She said there's a lot of community programs out there that to be able to catch that, and three, coming into the law enforcement side, in which you were speaking of, the training. We're already recommended funding for the sheriff department for the Narcan machines, for the TruNarcs to basically detect, and then we go more into the marketing and media side, number 4. So those are my 4 that I'm proposing that we go into.
I would echo that, and also the ones that, that pretty much goes along with what staff provided us.
The only recommendation I want to make, because you are getting, as you say, one-off requests, for example, you awarded some funding for the sheriff's office, you have the Pensacola Police Department asking, I know corrections is looking for similar detection things, that maybe not allocating 100% of it, but leaving you guys a pool of money just in case there's something else that may come outside the realm that you want to approve might be an idea. Otherwise, if you tie it all up, then you won't be able to.
Right.
I have a question related to funding overall, in terms of, as we look at when we put out requests for proposals, and considering, in one of the examples that we got, considered ongoing funding year after year. And so again, I think as we look at how we prioritize, and when we're actually going to request proposals, considering ongoing funding as opposed to one-year funding, it goes to your point in terms of how much do we allocate in a given year, or recommend allocating in a given year in these areas. So I just think we need to be cognizant of that as well.
I think that once we do the RFP process, Christy, correct me if I'm wrong, and you guys agree to a funding of a particular thing, they can put in the agreement with the option to renew.
Right.
But we would want to make sure that the reporting that they provide us is showing that they're moving the needle.
One thing that was included, are you speaking of this notice of, is that what you're referring to? Okay, so the sample, which is also listed on here, is the notice of funding for opioid abatement, but it's one that Lee County used. And if everyone on the board reviewed that, it did provide some, like you said, overall funding, and then basically parameters in which they could apply for that funding. So I feel like that would be something good for our county to potentially look at and use versus maybe specific RFP.
So I guess back to the point in hand, I would concur with the 4 areas that have been mentioned in terms of our priorities of community prevention, including community and primary prevention, and then treatment and recovery, those 4 areas. I agree with that.
Do I have a motion?
Motion.
And could you state the areas again, just so that we have that, we have treatment and recovery,
Yes.
prevention, training, and marketing needs?
Under law enforcement, just keeping in line with the survey.
So law enforcement would be number 3.
And then the marketing, under the marketing campaigns, get things out, hey, like, this is what it is.
I do want to make the comment, when we get specific on marketing campaign, I think if we keep it more in a broader term, such as overdose prevention, treatment aspect of it,
So you actually would be okay, probably, just that marketing piece really falls in the prevention categories.
Right.
The community and the primary prevention, so you probably only need 3.
Okay, thank you. Thank you for that clarification.
And just keep in mind what you're doing here today. I just want to make sure we are on the same page, because the actual competitive solicitation is going to be done. It'll have to go before, it'll go before the board, before the competitive solicitations are issued. The BOCC is not coming from here. So you're just
Correct.
coming up with
We're making a recommendation.
Right, you're coming up with your priority list. Okay, just making sure we were on the same page.
Yes.
And under these priority lists, do we have to dive deeper into the subcategories where we want to see these priorities listed out or whatnot attacked?
So you really have 2 options. I mean, if these 3 categories, we can list the subcategories underneath them and just see what you get. I mean, again, we want to try to think out of the box. I don't know how much we want to put people into a box. It allows some more creativity on our community's side. If we narrow it down too much, I fear that we might not get as many responses, if that makes sense.
Yes.
And when we get a response, we'll be able to review it and see if that program fits.
Yes, so the only thing I'm doing with this information is updating that implementation plan to reflect us. It'll come back to you guys, you review it, you can say, get rid of this, add this, whatever, you'll approve it. Based on that, the RFP can be created, and then that'll come back for you guys to review before it probably goes out as well.
And that'll all go through the BOCC before an RFP goes out. So the BOCC, so you have to decide, knowing your board, are they going to want more details? And that's something else they can ask you for. When they look at what you're presenting, and depending on when it's presented, it may be presented by you, Vice Chair. When it's presented to them, then they will make those decisions and say, we want more detail here. What do you mean by that? So you may be coming back and making more decisions, but really what you're doing is getting the ball rolling, so that the board knows what you're looking at and telling you, yes, go ahead, but with these parameters.
Thank you.
Thank you. Okay, so we're back to number 1, community. We're going to keep it as it's listed. And then number 2 is going to be primary prevention. And then 3, treatment expansion.
No, that's not how it, no. The
Treatment
first
and recovery,
was number 1. Number 2 was the
prevention.
Yeah, the community prevention, and number 3 was the law enforcement aspect.
I think the law enforcement aspect is a little more specific than the general categories we were looking at.
Well,
What do you- I'm
if
sorry, go ahead.
you also can, instead of listing out law enforcement separate, the training piece of it, the prevention, the treatment, the expansion still applies to corrections. But if you want it specifically and you want to make sure we target those, then I would leave it as a separate thing. But treatment and education, to me, applies in our jail as well.
So you're
Wouldn't-
speaking of just to have the 3rd one under corrections?
It would just be another population, just like our youth. We could do our correction individuals as a population, pregnant women, but it's all in how you guys want to lay it out.
But as far as laying out the three, like our goals here, we said the treatment and recovery, the community, which covers the prevention and things of that nature, under that community category that's right there under the survey. And then the third one would be under the corrections part, would be in the corrections category. Am I reading you right?
And do you want to do all law enforcement? So it could apply to police, sheriff, corrections?
Well, we kind of already done that because we've already approved the equipment for the sheriff. We have the Pensacola Police Department here today, and you said the corrections are already, kind of had those same kind of needs. So it is actually kind of running that entire gamut of corrections.
Okay, so I do want to point out that the only thing we've approved is equipment
Right.
to be able to find the drugs. It does not include any training or, for example, the Pensacola City Police Department has just hired 2 caseworkers.
Right.
And those caseworkers focus on homeless people, they deal with opioid people. So if you wanted to focus on those guys also getting additional training or learning how to transition folks that they find that are in addiction to other facilities, I mean, it's how far do you want to go with it?
I think if you put it under law enforcement, and then when we put and then you can put all those subcategories under law enforcement, whether it be corrections, whether it be the training for the opioid under the sheriff or whatnot, and then when we put out those RFPs, and they'll come back with their requests, and then that's how that would flow out. Okay.
My concern is, based on what we've spent a lot of time listening to today and looking at the prevention needs, the treatment needs, law enforcement wasn't our top priority. And so to put that as a third category as opposed to being subsumed under one of the other opportunities, to me, it's not consistent with what we've heard.
So what you need to know, what is your motion before the board right now?
We're kind of like in a discussion.
Right, you need to get your motion
Yeah.
with a second on the floor, and then have your discussion, because that's why we're getting off on other topics.
Well,
do
we're
I
on
have
the
a
same topic. We're just having the formality. You got the second?
Could you read the 4 areas that you provided again so everybody can get refreshed on that?
Yeah, so the first category was prevention. And again, this doesn't say it has to be a specific population, so it could apply to anybody. So it's community, which is funding for schools, childcare, family services, and job training to prevent drug use. Primary prevention, programs and strategies shown to prevent drug use, including family and youth programs that promote healthy behavior in relationships and reduce risk factors, as well as adult education programs and public education campaigns. So those 2 were underneath prevention. The second one was treatment and recovery. It's treatment expansion, which is expanding substance use disorder treatment, example, detox, inpatient, residential, and outpatient treatment, and medications for opioid use disorder, and then recovery support, programs that promote recovery, like access to housing and healthcare, employment and job training, and peer support programs. Those were the 4.
But they only come from the top 2 categories of the survey. That's what they was broken down in the subcategory. But if you look at the survey, there's a appetite from the community to say, hey, put money towards this in the law enforcement category. And so that's why I included it in some of our goals, because I'm going back to the community survey. Even though these were the top 2, but it was not the only 2 categories in which the community responded to.
And let me just refresh you guys on the criminal justice category so you know what the top 3 were in there. So law enforcement was funding and training for local police, drug task forces, and efforts that prevent illegal drugs from getting to their destination. Community corrections, develop and expand drug and family courts and other law enforcement programs that help people using drugs find treatment and stay in the community. And then post-incarceration social programs, programs that help people recovering from substance use disorders reunite with their communities following jail or prison time.
Just from a law enforcement standpoint, I don't think we need to focus too much on funding for the task force and stuff like that. There's other state funding that's been allocated for that. Probably the only needs locally that law enforcement would have would be some training and equipment, stuff like that. I think the other stuff, there's plenty of other funding for that.
So we could call that category criminal justice. I apologize. I was thinking law enforcement, but we could call it criminal justice because that's how it is laid out in the survey.
Okay, so we had the motion for the areas, which is going to be treatment and expansion, prevention, and the third one is going to be law enforcement, or the motion was not that. Law enforcement?
Criminal justice, because it,
So he can amend his motion
Okay.
Yes.
if the board's okay with that.
like to amend the motion is instead of law enforcement, so for the category instead of law enforcement to be criminal justice, because she so eloquently laid it out for us.
Second.
Okay. So that passes.
Did you vote on that, or did you just
Oh,
have a second?
I'm sorry, that was my fault. It's a long conversation. All right, so now we'll take a vote. All in favor?
Aye.
Okay, now it passes. Okay. The next item on the agenda is Pensacola Police Department, the True Narc kits. I don't know if they're going to have someone that speak to that.
Good morning,
Good
Vice
morning.
Chair and committee members. Eric Randall, Police Chief for the City of Pensacola. If you recall, I was here months ago for a request for the very same items. However, through no fault of our own, there were some things that had to be put in place. We thought it was on the Board of County Commissioners' agenda, but it had been pulled. And there's also an interlocal agreement that we have to put in place. We're working with the County Attorney's Office to make sure all that stuff takes place. But since then, through all the things that we have to do, the price of the devices have went up for the True Narc devices. So what we're requesting today is to have to purchase 5 True Narc devices for the City of Pensacola Police Department, and working with the County Attorney's Office through an interlocal, and we appreciate all the efforts of the Opioid Abatement Committee and the consideration from that.
What did the total go up to, Chief?
Let me just a second. pull it up.
Actually, Chief, if you don't mind, I can give you that information, but I do want to, on the invoice itself, or there was one on your line item that talks about the True Narc solution kits for $692, and you wanted 5 of those. The cost of that should be $3,460.
Okay, yes.
So that was a change that needs to be made, or I noticed. So back to your question, I believe the total funding, additional funding that will be needed to cover that is $72,066.
Yes, because
If
I
I'm
believe
correct.
Yes, I believe the original request was like 80,000, but with the price increase and then the addition of the 2 cents the price increase, that is correct. Yes, ma'am.
Yes, sir. The original amount was $80,379.
And the new amount is $159.89, is that correct?
It will have to be amended because there are a couple errors in the quote, because we're looking for a quantity of 5, and that number for 692 is not correct. I think it was 3,000 and something.
It's $3,460.
Yes, ma'am.
So the additional funding that they're requesting at this time to cover that would be the $72,066. Do I have a motion or discussion?
So move.
I'm sorry.
A motion and a second, and then you have your discussion.
Okay.
Second.
Any discussion? Okay, we'll take a vote. All in favor?
Aye.
Aye. So that passes, and then this will go before the board for approval. Okay?
Thank you.
Thank you.
Before it goes before the board, what you would probably want to do, I know you didn't get it much chance of a discussion because you would have already voted on this before. I just want to make sure that your reasoning for this is that it's the prevention of further abuse or hospitalization of first responders. So it goes within our strategies.
Yes,
Okay.
thank you. Since there are no other items on the agenda, then I move to adjourn the meeting.
I have a question before we do that.
Oh, go ahead.
And the reason, this is the question. So, in the last meeting, we had the same thing, these requests of funding from these other 3 agencies with this same thing as the police department. So, we've voted to move on funding for the sheriff, to send it up to the BCC. We've done it, we've done it right now for the police department. Why can't we do these other 3 also? I'm not understanding why we have to hold up for them. We're not doing an RFP for the sheriff nor the Pensacola, the police department.
Can you clarify that, Chris?
So under your duties and funding, what you're working on right now is your annual report. If you look in your bylaws, that says that you'll provide the county with an opioid abatement funding advisory board priority list for the county to perform competitive solicitations for program and services in accordance. So now you're working on the other program. There are other things that will come up during the year that you go, hey, this needs attention. Just like coming up with having Narcan available, and you already voted on that, to have the Narcan. So you're not going to devote 100%, like she was saying, like Liz was saying, you're not going to devote 100% of your funding to one project, or 25%. I wouldn't even recommend that you put a percentage amount on it.
Correct.
So there will be things that arise during the time that you come up and you go, hey, this needs to be taken into consideration, and you can do that by sending it to the board. But when it comes to this list, it is what Liz is working on for you. It is your duty to compose that list and send it to the board.
Not saying that we're not. We're doing that.
Right.
I'm saying from the last conversation we had, we said if there's community partners that's already there, then we could move to fund them without having to go through that entire process of RFP and things of that nature. And am I not correct?
Unfortunately, for community partners, we do need to ensure that they have been established a certain amount of time. They are registered as a nonprofit. They do have the financial capability to receive funding, typically on a reimbursement basis. There's a lot more T's we have to cross and I's we have to dot when it goes to giving money out to community partners. When we're dealing with constitutionals like the sheriff's office, it's typically we can allocate those types of funds. There's no reporting, they're machines. Now, I don't know, this is before my time that you guys started voting on these things, so I'm not sure if there will be any kind of reporting required by these folks or not, but typically, for example, the core team. If the core team came and they requested funding because they're a Escambia County, they wouldn't have to go through the RFP typically. They'd be able to come to the board because they work for Escambia County. So there are certain exceptions, I guess, or if our CMR team wanted to do the marketing plan, they wouldn't go through the RFP because they're Escambia County. So there are certain entities that are a little bit different than when we're dealing with outside agencies.
Okay, with that being said,
Also, part of this funding belongs to the city of Pensacola.
great.
So for us to ask them to do anything when it's their money would be, it wouldn't make logical sense, I guess.
What do you mean, ask who to do?
The city of Pensacola to ask for this type of funding, for them to have to go through the RFP process when it's their money.
Okay, with that being said, and that's great. I'm glad we're able to take care of the city on that. But we have had a request from the core program. We've had a request from Lakeview already, and from the Hoops organization. So with that being said, okay, so the Lakeview came with the Trace on October 2nd and said they needed funding for their Trace program. Then you have CDAC that needs funding. So do they have to wait to go through that entire process when they're already already contractual with the state in order for us to just go down and approve their funding? Because Chief is right there. Can we not just approve what he's asking for?
For the core program, we could, because again, it's Escambia County's money, and they're Escambia County. But Lakeview, CDAC, they'd have to go through the RFP process.
Okay. Well, with that being said, I'd like to just get one out of the way today. I'm gonna like to make another motion that we approve the funding of $500,000 that the core program asked for this past year.
You can't, that's not on agenda. So you can't take something out of agenda.
Okay. Well, can we make that on the agenda for the next meeting, please? I apologize.
For clarification, I don't recall the core program requesting money
You know, some of
specifically.
these things were information that we received, but it wasn't an actual request for funding.
When he came last time, he said he had a shortfall in his budget, and he was needing that shortfall to continue services because they were running out of funds for the core program. And we kind of put it off to, again, the beginning of the year, and we're here, and so I'm trying to figure out where we are, Chief.
So if I may, to kind of help clear this up a little bit, I was gonna put this out there a little bit earlier, but there's been a lot of different topics going around here, and I understand we're trying to work through this. So one of the things that needs to be made clear and very transparent is, as I suggested when we first started, we fell under the Department of Health, which was through the state of Florida. And we are still probably close to $300,000 in the negative that they have not reimbursed us from last year's costs for core. That all came straight out of EMS because those aren't tax dollars either. EMS pays for itself. We are an enterprise organization. We have to generate our own funds. So in doing so, now this year, while we're still trying to recoup those funds, we have a much better pathway with Northwest Florida Health Network. As I suggested to Dr. Williams, you know, they're paying us monthly. They just took the total amount we asked for, divided it by 12 months. It's the easiest way to do it. However, they also are not on any given timeline. It is, we'll fund you this year, we'll see how next year works. So being that we are already in the negative, probably close to $300,000 from the funding we were supposed to get, as well as this not being a guaranteed thing, those were the reasons, as you said, Mr. White, previously, that I brought forward was we have to have a sustainable measure. If for some reason any of these other funding sources say, sorry, you're done, I can't just drop the core program and let all these people falter. And the only way to do that, and I think it was the first or second meeting, you have to forgive me, I remember some attorneys coming in with a big list of here's the opioid abatement, and it was like 18 years or 20 years or some number, you have to forgive me, guaranteed. And the number kind of changed a little bit every year. And in separate conversation with my boss, the public safety director, and the county administrator, we said, listen, that is a more sustainable route to know that we will have this program no matter what happens with these other entities that are funding us. Because while they've proven to be true, at least with Northwest Florida for sure, I can't guarantee next year they're going to come back and go, yep, you're getting the same amount, or sorry, we had to cut it by half. That would be detrimental to this program. So that's where that came from, just as a revisit. But I also do understand that this still needs to go through a process. What I would do is it would be forwarded to Liz. It would obviously go through county. It has to go through the board agenda and be sent forward as a county entity to request those funds. But that can very simply be done as well. I mean, am I speaking out of turn there, Christy, or is that the process we need to go through?
I would have to go back and look closer what core is allowed to do and what these funds are allowed to support. So that would be a more in-depth look, because there's going to be some things that, as I recall, core as it was set up, it is funded by the county. That's its net if anything fails. Right.
So-
The positions that have been put in place are funded. And if something goes wrong, the county anticipates being able to fund the new positions.
No, the county, so those personnel that we have right now that work full-time for core, when they're hired under the guise of this is outside funding, and if the funding goes away, your position is not guaranteed.
Okay.
That is why I have worked diligently to try to get a safety net, because when this first came out from the state, it was, look at this amazing, wonderful program, and then it kind of, all the different counties, we were actually one of the first to get ours up and running and really start treating patients to the level that we are. And then when we found out that this money is not guaranteed, that was when I escalated up the chain and said, hey, this is great, but we need to have something sustainable. And that was the venue that I had spoke, as Mr. White was indicating. I said, listen, 500,000 is what we're going to need because I think our budget is almost right at that right now. And with the addition of personnel that we would absolutely need in order to grow and make this happen, that would be extremely beneficial. And to your point, when you talked about criminal justice, one of the things I wanted to make clear, this goes back about 1.5 years, 2 years. I sat in a judicial mapping session with, Chief Powell and Ginger Madden, and a lot of people discussing about what happens to these folks when they get into the corrections. And one of the things that was brought up that we believe we have nearly rectified was, what happens when a warrant catches up with someone that is in our core program? And they've been in for a while, and we've got them on MAT, and they're doing well, and they're off drugs, but they have to go to jail. The jail doesn't allow them to get the MAT that we give them. They only allow the Vivitrol injections, which are very expensive and is a completely separate process that we don't offer. And when I brought that up in that mapping session, I just kind of got that, well, we're not going to let that in the jail, and that's not going to happen, and yeah, there's nothing we can do about it. And I said, so if I have somebody that's got 6 months of traction, of sobriety, and they have to go to jail because this happened, but we'll get it worked out, they're going to go back and start at day one again, simply because of that. We have now recently, through Joey's efforts, been able to meet with them and with Chief Powell, and we are now doing a proposal where they are accepting of us coming over as a core program doing medication-assisted therapy with those in the corrections facility through EMS, just to make sure we don't lose those that we've had in our program and have to start all over from day one. So I think it was imperative that you knew that piece as well. We are working with the corrections department, for those processes.
I just would say I can certainly work with the core team, and that might be one of the things where we just set up a certain amount every year that kind of to build up even some reserves in case something were to happen. But I'll certainly work with him, and then we'll get it over to Christy and Tina and make sure we do our due diligence to bring it back.
Can we get the core program on the next agenda? And Chief, can you be here next meeting with your formal request, please?
Yes, sir. Yes, sir.
Thank you.
You would just need to send that to Tina.
Right, with your, you can't just bring it in. You have to, first of all, it's going to have to be approved by Vice Chair. We also need a meeting date. I don't know if we have one.
We don't have one, so if everybody will look at their calendar.
Okay, thank you. Can I say one thing? I gotta say this. We've been doing this over a year or so now, and every time that there's situations brought up, and Christy, I love you for your professionalism, and you're a very, very smart woman, and you're a legal beagle to the T of the letter. But, and I know we're working out all of these structures, but it just seems like we're making it awfully hard to get the funding out of our hands up to out of the county's hand and city hands into the folks' hands that are boots on the ground. I'm gonna tell you something. I know it's, people's, we're here, things of that nature. We're on these boards, we're in the offices and things of that nature. But unless we want to do what they're doing and these other people are doing, I think we need to get the people the funding that are front lines, front and center every day. And we need to make it as simple as possible. And I understand all the legal stuff, I understand this, but we have an entire situation right here. And I read this, I actually read this. It's not a thriller by any means. But this says, our Bible says, here it is. These are your strategies. Here's the funding. Let's get it done. That's what it says. When you go through all the legality, all the etats and all the stuff that we do from a legal basis, that's what it's saying. And I don't think we need to just make it so challenging. And we already see these people, we know these people, we know these organizations, we know what they're doing, and they're doing a hell of a job at what they're doing for them to continue to do the great work that they're doing. And that's my last thing.
Okay. We're back to scheduling a date for our next meeting. Any recommendations? March the 4th? Will that work? Does that work for you, Tommy?
That doesn't work for me.
Okay.
The 11th would work.
Which one?
The 11th, March 11th.
That works for me. March the 11th?
And I hate to be difficult. And I know we voted to go every other month, things of that nature. But I'm asking the board, can we meet next month so we can go ahead on and get these things, these priorities knocked out, laid out, so we can put these RFPs out, and so we can possibly go ahead on and get the funding approved for Chief and the core program, and then we can do every other month after that, because we've already been a year plus, and we need to get this thing situated, and then we can move forward after that. Can we please do that?
What date would you like to select?
Whatever day you guys
for
want in February,
February.
I'm good. It can't do
The 12th?
The 12th will work, 5th or the 12th will
How's the
work for me.
12th work for you? Will the 12th work?
yes, we can do, yes, that's great for me.
Okay. We'll schedule the next meeting for the 12th at 10 a.m.,
Yes, ma'am.
and the meeting is adjourned.
Thank you all.